In chapter 38, we're going to talk about liver diseases. So we'll first start out talking about the structure and function of the liver. It's the largest parenchymal organ of your body, so this means that it has sort of a solid structure to it. It's located in the right upper quadrant of the abdominal cavity, just beneath the respiratory diaphragm, and it's divided into two main lobes. We have a right lobe and left lobe of the liver, and blood supplied to the liver through two main mechanisms. We have arterial supply through some hepatic arteries. About a quarter of the blood that reaches the liver comes from these hepatic arteries. And the other 3/4 comes from the hepatic portal circulation. So remember, from all the digestive organs in your abdominal cavity, spleen included, so spleen, stomach, small intestine, large intestine, all of the veins from those organs converge into one big vein called the hepatic portal vein, which brings nutrient-rich but oxygen-poor blood into the liver for liver processing. Now, just looking at the structure of the liver here, we see this is an anterior view, and this is the respiratory diaphragm. You see that the liver has one large right lobe and a left lobe. They're separated by a falciform ligament. And it turns out that someone actually can receive an entire lobectomy of the liver, and a new lobe can actually regrow, which is actually pretty cool. Now, from a superior view of the liver, what we see here is that it's also nearby some other structures like your esophagus, as well as the inferior vena cava. So, liver neoplasms may actually impinge on something like the esophagus or inferior vena cava, depending on the location of that neoplasm. Now, the right lobe also has the gallbladder associated with it because we know that the liver, one of its functions is in part to synthesize bile and then store that bile in the gallbladder until it's secreted during digestion. Now, what this slide is showing is basically the hepatic portal circulation. So you can see that from the spleen, stomach, pancreas, small intestine, and entire large intestine here. All the veins of those particular organs converge into one large hepatic portal vein, which then brings that nutrient-rich but oxygen-poor blood into the liver, where the liver then processes that blood in a variety of ways. Now, although that this blood is oxygen poor, the liver still receives some blood supply through a hepatic artery, which is a branch of celiac trunk, and so it does receive some oxygenated blood as well. Now, eventually, these hepatic arteries and hepatic portal vein converge at liver lobules and then all drain together through the hepatic veins back into the inferior vena cava and then back towards the heart where it's all recycled again. Now, as a digestive organ, the liver is involved in synthesizing and secreting bile salts, which are involved with fat digestion. Now, the reason why we need bile salts for fat digestion is that fats are hydrophobic, which basically means they don't like to dissolve in water. So in the watery environment of the food that you've ingested, it turns out fats like to separate from the rest of that food, and they're going to separate into larger globules that have less surface area. And so in order to increase the surface area for digestion on those fat globules, bile salts help emulsify those fats, or basically break apart a larger fat globule into smaller pieces. And by breaking that into smaller pieces, then we can actually digest it more readily and absorb it more readily as well. Now, some other digestive functions of the liver include things like storing fats, carbohydrates, proteins, vitamins, and some minerals. And as an endocrine organ, it's involved with regulating things like carbohydrate, fat, and protein metabolism because it's sensitive to certain hormones that help regulate this type of metabolism. It's also involved with the breakdown of glucocorticoids, mineralocorticoids, and sex hormones. And remember from previous chapters, we talked about how the liver also synthesizes angiotensinogen, which was the precursor to angiotensin 1. So as an endocrine organ, it's actually involved with in part helping to raise your blood pressure. Now, as a hematologic organ, it can be involved with the temporary storage of blood. This is what we talk about is it being a venous reserve organ. And it's also involved in hematopoiesis. Under very extreme circumstances, new red blood cells can be formed by your liver. Otherwise, the liver helps synthesize things like blood clotting factors and clotting proteins, as well as removal of bilirubin from the bloodstream. There are liver cells called Kupffer cells that actually break down damaged red blood cells or free bilirubin in the bloodstream. And it takes those components from the damaged red blood cells or bilirubin to turn that into bile. And so in part, the liver helps remove this sort of bilirubin or damaged red blood cells. Now, as an excretory organ, it helps excrete things like wastes such as urea or different drugs and foreign substances. But it also helps excrete bile pigments and cholesterol. Excess cholesterol is actually excreted by the liver, and these bile pigments like bilirubin are also excreted by the liver. And so it turns out that bile pigment and cholesterol are incorporated into bile, so that not only is bile involved with digestion, but it's also an excretion because there are wastes that can be eliminated from your body via bile. Now, in terms of some of the general manifestations of liver disease, we have, hepatocellular failure, or basically failure of the liver cells, can lead to a variety of things. It can lead to things like jaundice or a decrease in clotting factors. Jaundice, remember, is sort of a yellowing of skin and other tissues, and this is due to an accumulation of bilirubin in those tissues, because if the liver can't adequately remove that bilirubin by incorporating it into bile, then this can lead to jaundice later on. Now, we know the liver also synthesizes clotting factors, so if the liver's failing, then it can't synthesize these clotting factors as well, and so someone can actually be at higher risk for bleeding disorders. The liver also synthesizes albumin. Remember, that was one of the major osmotic driving forces of your bloodstream, so that if your liver's failing, then you see a hypoalbuminemia and all of the sequelae that result from that. We also know that the liver is involved with storing certain nutrients like fat-soluble vitamins, so like D, E, A, and K. But what we'll find then is that due to a decrease in the available storage of D and K, then we'll see things like osteomalacia, which is due to a vitamin D deficiency in adults, as well as poor blood clotting factor production, and that's mediated by vitamin K. So, we need our liver to store these vitamins in order for adequate bone health and adequate blood clotting. Now, the liver also receives a tremendous amount of blood flow from your digestive organs. Remember, we talked about how that's the hepatic portal circulation. Now, if the liver is failing to digest that blood, then you're going to see a congestion of blood in the hepatic portal circulation, and that can lead to what we call portal hypertension due to this congestion of venous blood in the abdominal organs. Now, this can lead to things like gastric or esophageal varices, which are basically like protrusions of blood vessels, kind of like hemorrhoids, but into the esophagus or stomach. It can also lead to hemorrhoids because the rectum also is what drains blood into the hepatic portal circulation. But can also lead to things like splenomegaly, which basically means large spleen due to a backup of blood in the spleen. And even ascites, which is basically edema in the abdominal cavity. I mean, we can estimate that if venous blood pressure is rising due to GI congestion, then water is going to be forced out of the bloodstream into the abdominal tissues due to this increase in portal hypertension, and that can contribute to what we call ascites, which is essentially edema within the abdominal area. Now, in terms of jaundice, there's different causes of jaundice. We talked about how with the liver's failing, that can lead to jaundice, and that will be a hepatic cause of jaundice. So dysfunctional liver cells can lead to an increase in bilirubin concentration throughout your body's tissues, causing a yellowing of the skin and sclera of the eye. Otherwise, not all forms of jaundice are necessarily caused by liver failure. We have prehepatic and posthepatic causes of jaundice. Prehepatic jaundice would be caused by hemolysis or abnormal breakdown of red blood cells, or ineffective erythropoiesis, or even resorption of large hematomas. So that due to something else other than the liver and things that kind of come before the liver, you might have abnormal breakdown of red blood cells, abnormal red blood cell production, so they might just be malformed, or even due to blood clot formation. Once that's resorbed, that can lead to a lot of bilirubin in the bloodstream. So these are all prehepatic causes of jaundice. Posthepatic cause of jaundice would be at the level of bilirubin transport, where what we can find then is that mechanical obstruction of the bile ducts can lead to a backup of bile in the liver, and therefore a backup of bile into your body's bloodstream and tissues. And this can lead to hyperbilirubinemia. Now, portal hypertension we talked about was a congestion of venous blood in the portal circulation. And it's due to sluggish blood flow that results from increased pressure in the portal circulation. And this congested venous drainage of the GI tract leads to things like varices. And these varices are basically protrusions or dilations of of vessels that are basically part of the portal circulation. This can occur in any organ that actually drains into the portal circuit. So the esophagus, the stomach, the rectum. If these varices form, they can rupture, and this can lead to uncontrollable bleeding. Now, portal hypertension can also promote ascites, which is an accumulation of fluid within the abdominal area as well. Now, these gastroesophageal varices are just a complex venous network, and you can find these commonly around the stomach and esophagus with portal hypertension. Now, you'll see them forming as a consequence of high portal pressure, and it leads to massive life-threatening upper GI bleeding if they rupture. So here's what they look like. These are the veins that would drain into the portal circuit, and you can see here that if blood's backing up in these portal veins, or the veins that contribute to the portal circulation, because the liver can't adequately process that blood fast enough, then these veins can start to protrude and distend into various areas, including the lumen of the esophagus or the stomach. Now, this protruding of the vessel here, we call a varix, and the wall of this is actually fairly weak. So you can imagine if someone ate some food, and if that food were sharp or at least traumatic enough to rupture this varix, it can lead to uncontrollable bleeding within the esophagus and stomach, which can be life-threatening. Now, another interesting sequela of liver failure is hepatic encephalopathy, and it's a complex neuropsychiatric syndrome from too much ammonia in the blood, and it's associated with hepatic failure or in chronic liver disease. But due to this ammonia accumulation in the bloodstream, you'll see things like dementia, psychotic symptoms, as well as cerebellar and extrapyramidal signs. So they'll have difficulty with normal movements. And these are sort of an odd neurological consequence of this waste, ammonia, building up in the bloodstream due to liver failure. Now, ascites is actually an accumulation of fluid in the abdominal cavity, and it's a pathological accumulation of fluid. Now, this can occur with portal hypertension or hypoalbuminemia, which we talked about in the renal chapter, because albumin helps retain water in the bloodstream, so that if you lack albumin due to, say, nephrotic syndrome in your kidneys, and you start to lose this albumin, that can lead to excessive accumulation of fluid throughout your body's tissues, especially the abdominal cavity, which then we would call ascites. Now, that can also lead to cerebral edema, and interestingly enough, cerebral edema results from hypoalbuminemia due to liver failure, and this can lead to swelling within the cranial cavity because of fluid loss into the cranium. This can also lead to a decrease in brain perfusion if intracranial pressure rises too much, and it's the major cause of death with acute hepatic failure is due to loss of albumin, or at least decreased production of albumin. This can lead to cerebral edema that's eventually life-threatening. Now, in terms of other disorders of the liver, we'll start with acute viral hepatitis. And we define this as sort of inflammation of the liver parenchyma, or tissue itself. And it's caused by many different types of viruses. Things from cytomegalovirus to Epstein-Barr virus. And there's a different class of viral hepatitis we talk about, like A, B, C, D, and E. And they can be caused by different viruses, but they're sort of defined alphanumerically. Now, hepatitis A is an RNA virus that's spread by fecal-oral route, also called enteric hepatitis for that reason. It has about a 2 to 7 week incubation period, and during the prodromal period, what you might see then is jaundice, right upper quadrant pain due to inflammation of the liver, malaise because of inflammation, anorexia, nausea, low-grade fever, and in children, they may actually not experience that jaundice you see in adults. Now, in terms of hepatitis A infection, after the initial infection, it can be followed by jaundice for approximately 2 weeks, and fortunately, it's a self-limiting course, and so your immune system can typically eliminate hepatitis A on its own. Now, with hepatitis B, it's a partially double-stranded DNA virus, and it's spread by parenteral contact with infected blood or blood products, and this includes contaminated needles or sexual contact. And there is also a prodromal period here, and it's asymptomatic, or you might get things like rashes, joint pain, angioedema, so edema around the heart, serum sickness, glomerulonephritis, or inflammation of the glomeruli of your kidneys, or even jaundice that can last 2 weeks. And this affects about 1 to 1.25 million people in the United States. So remember, it's actually spread by needles and sexual contact. Now with hepatitis C, it's an RNA virus, or flavivirus family, and it's spread through IV drug use. And prior to 1990, we didn't have an effective way to screen for hepatitis C in blood, so that if you received blood transfusions before 1990, there's a risk that you could have contracted hepatitis C from that transfusion. Now, acute hepatitis C infection can be asymptomatic, and the course can be erratic with wide fluctuations in liver enzymes. And with chronic hepatitis C infection, it can also be asymptomatic until advanced liver disease takes hold. And it's one of the most common causes of end-stage liver disease that it also leads to cirrhosis. So, this is sort of an insidious disease because someone can be infected with hepatitis C and be totally asymptomatic until liver disease is totally advanced and irreversible. And at that point, then they, would need to have medical intervention, or possibly even, as long as the infection's no longer present, could be a candidate for liver transplant. Now with hepatitis D, we call this Delta virus. It's an RNA virus that actually is a co-infection with hepatitis B. So what's interesting with hepatitis D, it's actually a virus that requires hepatitis B infection to already be present, and it uses hepatitis B machinery or sort of proteins to help replicate. And what's interesting is that if someone has hepatitis B infection and then gets infected with hepatitis D or Delta, it actually worsens the hepatitis B infection symptoms. And prevention of hepatitis B also prevents hepatitis D infection because these seem to be cofactors. It turns out that hepatitis D seems to be transmitted by parenteral and intimate contact. Now with hepatitis E, it's also an RNA virus spread by fecal-oral route. You find this in contaminated water supplies or parenteral transmission. It's more common in developing countries, or if you've traveled to regions and been exposed to contaminated water. And it has a relatively high mortality rate for pregnant women, and the incubation period for hepatitis E can be about 2 to 9 weeks. So, you can travel overseas, come home, and then weeks later eventually develop signs and symptoms of the infection. Now, with chronic hepatitis, we talk about this as sort of a group of diseases that lead to inflammation of the liver that lasts longer than 6 months. And there's 3 main subcategories of chronic hepatitis. We have chronic persistent, chronic active, and autoimmune hepatitis. With chronic persistent hepatitis, it's progressive destruction of inflammatory disease of the liver for more than 6 months, and this may lead to cirrhosis. With chronic active hepatitis, it's inflammation that's confined to specific regions in the liver, like the portal triads, and this might not damage normal liver structures, but it may lead to a disruption of portal circulation. And autoimmune hepatitis is basically where someone's immune system starts to attack their liver. So cirrhosis is irreversible end-stage liver disease that can be caused by a variety of hepatic injuries. It can be caused by severe acute hepatitis, chronic hepatitis, or even toxic hepatitis. It can be caused by metal storage diseases that we'll talk about later, as well as alcoholism. Now with cirrhosis, eventually what happens is the liver becomes fibrotic and scarred, as well as nodular. And what ends up happening is that the hepatocytes eventually get replaced by adipocytes or fat cells. So it ends up making the liver look kind of more whitish and fatty and nodular rather than gray and smooth. And it results in permanent alteration of hepatic blood flow and liver function. And so what this slide is showing here is the normal healthy liver on the left. It should normally be kind of a grayish red and have sort of a smooth surface to it. On the right here, this is showing liver with cirrhosis. And you can see here that the liver is actually kind of whitened due to accumulation of fatty acids and adipocytes that have now started to grow within the scar tissue. And these nodules that form on the outer surface of the liver as well. So we call this a cirrhotic liver. Now, there's different types of cirrhosis. We have biliary cirrhosis, primary sclerosing cholangitis, as well as alcoholic fatty liver. With biliary cirrhosis, this is actually the end result of continuous ongoing inflammation of bile ducts and biliary obstruction. So things like cholelithiasis can lead to biliary cirrhosis due to a backup of bile that actually leads to liver damage. Otherwise, there's also transmissible parasites like the Lancet liver fluke, and this can actually live in the portal system, and it can also lead to cirrhosis of the liver. Now, with primary sclerosing cholangitis, or PSC, It's an autoimmune condition that can be co-seen with ulcerative colitis. So somebody with ulcerative colitis may also be at a higher risk for primary sclerosing cholangitis. So you can see things like inflammation of the large intestine and the liver. And if it progresses, it can lead to cirrhosis. With alcoholic fatty liver, what we find here is that due to chronic alcohol exposure, this leads to fat accumulation in the liver cells, and it's associated with alcoholism and end-stage liver disease. Now, some toxic liver disorders are basically going to be where your liver is subject to damage because of its storing and detoxifying of injurious substances or toxins, and metal storage diseases kind of fall under this category. And so there are certain hereditary diseases where individuals can store excess amounts of things like iron or copper, and this can lead to damage to the liver. We'll talk about things like hereditary hemochromatosis and Wilson's disease. So with hereditary hemochromatosis, it's one of the most common autosomal recessive disorders worldwide. It seems to be very prominent in Europeans, and there are some hypotheses about why this exists. Why do Europeans have hereditary hemochromatosis? Where it's basically a condition where people end up storing an excessive amount of iron throughout their body, especially in places like the liver, the pancreas, and the heart. Now, this can progress to hepatocellular carcinoma or even cirrhosis, but what's interesting too is that for those individuals with hereditary hemochromatosis, they seem to be more resistant to tuberculosis infections because of the way they store iron, and because macrophages lack as much iron in individuals with hereditary hemochromatosis. It turns out tuberculosis can't survive very well within a macrophage, so that for individuals with hereditary hemochromatosis, they're actually better able to fend off tuberculosis infection. So while TB was sort of roaring around Europe, individuals with HH may have been sort of protective against that sort of infection due to this particular toxic liver disorder, which is actually pretty interesting. Now, it actually there's an identifiable gene mutation, so individuals can be screened for this mutation. Remember, it's autosomal recessive, so you need to receive both defective copies of this HFE gene. Now, with Wilson's disease, it's also a metal storage disease, but instead of accumulation of iron, we see that it's actually an accumulation of copper. So, like hereditary hemochromatosis, it ends up accumulating excessively within the liver, as well as other organs. In fact, if enough of this copper accumulates, it actually can change the color of the skin and the sclera, and as well as your iris. And it's linked to a specific abnormal protein, which can be genetically screened for. Now, it is an autosomal recessive disorder, so you have to inherit both defective copies from each parent in order to express Wilson's disease. But the clinical manifestations of this excess copper accumulation are going to be things like hepatosplenomegaly, elevated liver enzymes, movement disorders, dystonia, and rigidity of muscles, as well as certain psychiatric symptoms that are associated with excessive amounts of copper. Now, some other toxic liver disorders include things like acetaminophen poisoning. It turns out that if you overdose on this, it can lead to acute hepatic failure. So if you're exposed to more than 140 milligrams per kilogram, this can lead to the accumulation of a toxic metabolite, NAPQI, and this can eventually lead to hepatic failure, or basically death of your hepatocytes. And normally this metabolite is sort of rapidly detoxified by liver enzymes, but in overdose, this detoxification can be overwhelmed, and that can lead to actually liver necrosis. Now, liver abscesses are basically just other structural conditions that can occur. So an abscess may come from like an ascending biliary infection. We talked about how if someone has biliary stasis, that can put them at risk for a bile infection. And this can ascend up into the liver, cause abscesses within the liver, and otherwise abdominal infections can actually eventually reach the liver through areas like the portal vein or the bile system. And this is often caused by certain aerobic organisms as well as anaerobic gram-negative bacteria. And trauma can also lead to other structural changes in the liver. We can have injury from penetrating abdominal trauma or blunt trauma. Like a penetrating trauma would be things like a gunshot or stab wound, or a rib fracture, because the liver is protected by some of your inferior ribs. If they fracture and then dive deep, the rib itself could actually end up piercing the liver. Now, this is life-threatening because the liver receives a tremendous amount of blood flow, so that with this sort of laceration or wound to the liver can lead to excessive blood loss, or even blunt trauma. If somebody gets hit in the right upper quadrant, it can lead to excessive bruising or hematoma of the liver. Now, because the liver is highly vascular and it receives almost 30% of your cardiac output at rest, this can lead to massive blood loss with trauma. So, liver injury is actually pretty life-threatening. And the liver is also a common site of malignancy because it also receives a lot of blood flow. It's a very common site of metastasis from, esophageal, stomach, colon, rectum, breast, and lung tumors because it receives a tremendous amount of blood supply and lymphatic drainage. The liver is a place where malignant cells have a tendency to like to stick. Now, primary liver tumors are pretty rare in the U.S. Like for the tumors that do occur in the liver, they are typically not of liver cells. They're usually other cells that have basically metastasized and deposited in the liver tissue. But liver tumors outside of the U.S. in the developing world are often caused by parasites, and that chronic inflammation and irritation due to parasitic infection can lead to primary liver tumor and cancer. Now, some candidates for liver transplantation would be people with end-stage liver disease that aren't responding to normal medical surgical intervention. This can be adults or children, but it's rarely performed if their liver is failing due to malignancy. And what this is showing here is sort of a liver with lots of abscesses all over it. You can see on the right here, and it's hypertrophied, much larger. It seems to be about 5 times larger than a normal liver, which you see here on the left. And this is it's considered more of a healthy looking liver because it's kind of a grayish, reddish, brownish kind of hue, and it has a nice smooth surface. So as far as we can tell externally, it appears to be like a fairly healthy organ. Now, there are other pediatric conditions that are associated with the liver, like abnormal bilirubin metabolism in neonates. What we find is that in newborns, if they have abnormal bilirubin metabolism, they can get prehepatic jaundice, and normally this is a harmless condition that doesn't last very long, much more than 2 weeks after delivery. But if there's too much bilirubin building up in the neonatal system, what we find is that this immature bilirubin can actually start to accumulate and potentially lead to damage of tissues like the brain. Now, some of the causes of abnormal bilirubin buildup in neonates might be abnormalities in transport mechanisms or conjugation, or like how it's stuck to other proteins, as well as the amount of gut absorption of bilirubin. Like if gut absorption of bilirubin is too high in neonates, that can lead to excessive accumulation rather than being excreted but through the feces. Now, kernicterus is one of those conditions where, due to hyperbilirubinemia or excessive bilirubin accumulation in neonates, what we find is that because of an immature blood-brain barrier in neonates, bilirubin's more capable of crossing the blood-brain barrier, and it actually causes encephalopathy because once bilirubin enters the brain tissue, it causes an inflammatory reaction that can lead to increased intracranial pressure. And what this looks like is sort of a yellowish staining of brain tissue, and it's permanent, so it damages the tissue permanently here. And it's associated with premature births or neonatal jaundice or even different hemolytic diseases. All these conditions that may cause hyperbilirubinemia. And in neonates, because their blood-brain barrier is not well formed yet, bilirubin can start to accumulate in the brain tissue. Now, for most infants that have this condition, they typically die of it because so much bilirubin accumulates so quickly, it's often irreversible brain injury. Now, Reye syndrome is one of those diseases of children that occurs shortly after viral illness, things like influenza or chickenpox. And it seems to be associated with aspirin use after the viral illness, and it's characterized by fatty infiltration of liver cells, which can lead to things like encephalopathy, clotting disorders like coagulopathies, and even elevated hepatocellular enzymes. So it's important to note that in children, if they've recently had the influenza or chickenpox viruses, then aspirin use should be limited as much as possible to avoid Rey syndrome. Now, some other congenital liver disorders include things like enzyme deficiencies or bilirubin metabolism or other metabolic pathways. So we see things like alpha-1 antitrypsin deficiency or cystic fibrosis can affect the liver. We have disorders of bilirubin metabolism like Crigler-Najjar or other metabolic inborn pathways where someone might start to accumulate a lot of wastes within their liver cells due to defects in waste breakdown, and otherwise like intrahepatic or extrahepatic conditions can also affect the liver.